Actually, today we will start topic of blood. Okay, so we will just try to correlate the basic concepts and the clinical problems or clinical things which are which you should be knowing. And okay, so just a second, please. Okay, so if I just ask you a question, what is anemia? So what will you answer? Who will answer? What is anemia? Yes, please. Okay, actually, blood is composed of RBCs, plasma, platelets, WBCs, clotting factors. Okay. And if we just consider to start with about RBCs. So anemia is anemia a sign or a symptom?
Sign.
Anemia may be a sign.
Sign.
Okay, so actually in some part of the world they will also that to be on a lighter note, that all mothers think that their kids are pale, getting pale. Okay, so actually that is anemia. Okay, so it is low hemoglobin, am I right? So what is the importance, why we are worried about anemia as an anesthetist? What is the issue?
Oxygen delivery.
Oxygenation, ventilation.
And not oxygen delivery is not something else. Oxygen carrying capacity. Okay, because there is one oxygen dissolved in blood. Okay, and one oxygen is carried by hemoglobin. So that is the main oxygen, which is delivery is something else. Delivery is something else. Okay, because there are so many other factors which are important for the delivery. What are those? What are those factors for delivery? Actually, that for that is cardiac output is needed. For that, oxygen tissue, the mechanism by which oxygen is unloaded by the RBC. Okay.
Mitochondria.
The concept of, no, that is oxygen utilization. Okay, that is another, because that is another step. So we are getting our discussion going by the word. So one is oxygen carrying capacity, one is oxygen delivery, and one is oxygen utilization. Actually, these three are different things. And even before that is oxygen transfer. Okay, so that is through the lungs. Then oxygen is carried by the hemoglobin. Then the oxygen is delivered by the hemoglobin, but there is a mechanism which is needed for unloading of, because there will be certain condition in which the oxygen hemoglobin, which we say that shift to the left, So what is that? That oxygen is unable to be unloaded from the hemoglobin. Okay. And there is something which you use the word this mitochondria. Okay. Mitochondria. So that is oxygen utilization. Okay. Because mitochondria is the powerhouse of the cell. So this is just we will slowly go into the details about each of it. So just to start our discussion, that actually why when we say low hemoglobin, that actually oxygen carrying capacity is decreased. So there will be signs of what will be the sign and symptoms of anemia. Like there will be some patient will be saying weakness. Okay. In patient may be saying this one shortness of breath. Okay. And if it is related here, they have written in a different way, but actually there may be the cause, the symptoms, not only because of the cause which is causing the thing which is the baseline pathology for the development of anemia. Okay. So generally, what are basic causes for anemia? Decreased production. Okay. Or impaired production. This is one reason. Okay. And then destruction. Okay. Or loss. Okay. Or you can say there may be in some condition the hemoglobin is not according to the need. Okay.
Functioning.
Yes, increased requirement. This will all result in the symptoms like anemia. Okay. And there is another condition of dilutional anemia which occurs in, for example, for instance, in pregnancy. Okay. So that will also be that is a slightly different, but it is one of the cause. Okay. So okay, if we just focus on the sign and symptoms, commonly like for example, actually I will go into the details for it, that because we divide anemia on the basis of cause. Okay. On the basis of RBC size, as like in the form of microcytic or macrocytic. Okay. And then etiology, like this is the same thing, etiology. And so if it is like if there is things related to decreased production, so the things which are needed are vitamin B12, iron, which is the main source of hemoglobin. Okay. And folic acid. Okay. What else? Is there anything which is needed? Just a second. Actually, I came from hospital a little late, so I couldn't prepare the things which I wanted to tell you in the way. But I'm just trying to take the things, move on. Okay, so what will be the other sign and symptoms in anemia? Okay, if anyone can just chalk out the sign and symptoms in anemia because of any cause, we will just chalk out what can be. One will be the pallor. Okay, paler we will see in the eyes, in the skin, okay, palm. Then if the depending on the stage of anemia, there will be signs of either increased cardiac output with tachycardia, okay, tachypnea, shortness of breath. What else? And if there is some individual, for example, in iron deficiency anemia, there are some changes in the nails. So it is koilonychia, which may be there. Okay. If there is some cause related to loss, so there may be history of hematemesis. There may be history of hematuria. Okay. There may be melena. What is then hematochezia? The fresh loss of blood in the stool. What else? There may be some internal bleeding. Is also, if it is the cause of anemia, maybe a bleeding disorder. Okay, so in that case, what else? What else? Okay.
Jaundice?
Jaundice can be there. Why? In which condition, which type of anemia there will be jaundice? It will be hemolytic anemia.
What the yes. Hemolysis, overdestruction, hepatomegaly.
Hemolysis, yes. With hepatosplenomegaly. Okay. What else? Okay, if we talk about cardiovascular system, in addition to, as I told you, there will be tachycardia and another finding of high output cardiac failure. There may be systolic murmur. Okay, systolic murmur. Okay, other thing may be the patient may be of any chronic disease like cancer, CRF, CLD. Okay. So this may be association with the anemia. Am I right? So you see, if we just see the hemorrhagic anemia, it may be due to acute, like any trauma in which there is bleeding. Okay. Or hematemesis may be a sign of lung cancer. Okay. Similarly, melena, epistaxis. Yes, epistaxis is usually related to, in which condition epistaxis occur? Other than, of course, ENT cause, hypertension. Okay. So maybe baseline hypertension may be leading to epistaxis, chronic epistaxis, and patient may be anemic. Okay. So similarly, there is another hookworm, like worm infestation. Okay. That will be usually in the babies. Okay. And in a female, excessive menstrual loss. Okay. Bleeding peptic ulcer. Bleeding peptic ulcer. In addition to that, anemia will be in bleeding peptic ulcer. There may be isolated because of this H. pylori, but maybe it is due to patients taking steroids. Okay, for any autoimmune disease. Okay, and patient having any rheumatological problem. Okay. So rheumatological problem, there will be additional reason for anemia. That will be because of bone marrow suppression. Okay. Because these patients may be taking immunosuppressants. Okay. So there we are just trying to figure out some other causes or some other presentations or relating, because now whenever you are taking any of the, like for example, if the patient is with epilepsy, patient is taking anti-epileptics, okay, so they may be causing bone marrow suppression, okay. So that is, I'm just trying to see in a broader view, anemia is like, you can say it is just like any worm which is, or cockroach which may be there in any home, okay. So anemia is associated with so many things, okay. So you just have to make your concept very clear, okay. So other, as I told you, I will just try to go into the details of the physiology in later our sessions, because actually earlier we were just trying to do everything in hurry. So now I will be trying to go in a little bit more detail. This week, whole week, we will just try to do blood, okay. So I will just try to give you an overview what will be our goals in this week, the whole of the week, okay, ending on next Saturday, like coming Saturday, okay. So anemia of chronic disorder, rheumatoid arthritis, as I told you. In CRF, it is related to, what is the reason for anemia in CRF? Erythropoietin production, okay, is decreased. There may be other reasons for anemia in CRF that may be related to platelet disorder and bleeding, okay. And there is another terminology of anemia of chronic disease. Okay. So what is the concept? We will just try to know about these three terminologies. What is MCH? What is MCHC? Actually, in the morning, I just try to Google and make the screenshots for it. Okay. So MCH is the average mass of hemoglobin per red blood cell. Okay. So they take the whole number of RBCs and they divide it by the whole number of like they take total hemoglobin and divide it by the total number of RBCs. Okay. So in iron deficiency anemia, because there is problem related to hemoglobin synthesis. Okay. So this MCH will be decreased. Okay. When hemoglobin synthesis is reduced or when RBCs are smaller than normal, such as in cases of iron deficiency anemia. Okay. So this is just one thing. And there is another concept of, see, so this is hemoglobin per RBC. Okay. So what is MCHC? Okay, MCHC is mean corpuscular hemoglobin concentration. So this is a measure of concentration of hemoglobin in a volume of packed RBCs. Okay, so it is calculated by dividing the hemoglobin by the hematocrit. Okay, so whatever hemoglobin is there, we divide it by hematocrit. Okay. So in iron deficiency anemia, both MCH and MCHC will be decreased. Okay. So okay, just a second. Okay, so what is significance of MCV? MCV actually it is related to the size. Okay, it is the average volume of RBC corpuscle or RB cell or red cell. So in cases of macrocytic anemia, which occurs in alcoholic patients, and vitamin B12 deficiency anemia. Okay. So I'm sorry, this. And in iron deficiency anemia, there is microcytic anemia. Okay. Okay. Macrocytic, this pernicious anemia, it is related to which part of the body? Pernicious anemia. Do anyone know? Yes, please. I'm sorry. Say again.
Stomach and duodenum.
Yes. Okay. So it is related to vitamin B12 absorption. Okay. And as I told you that iron deficiency anemia or any anemia in which there is loss. So there is production, rapid production. So the RBCs which are formed are usually microcytic. Okay. So you see gastrointestinal blood disorder, menstrual disorder, thalassemia, and sideroblastic anemia. These are causing microcytic. Okay. Okay. So when there is the deficiency of vitamin B12, it is also having some neurological symptoms. Okay. And if I'm not wrong, there is a syndrome which is because of esophageal web. And I cannot recall what is the name of that syndrome with iron deficiency anemia. Can anyone recall? Plummer-Vinson syndrome. Am I right? If I'm not, I cannot recall exactly. I think it is the same one. Can anyone correct me? No, you have to confirm it. Plummer-Vinson. Yes. Okay. Iron deficiency anemia with the esophageal web and dysphagia. Okay. Okay. So which endocrine problem will have anemia? What about thyroid disease? Can there be anemia in thyroid disease?
Kidney, I think.
I'm sorry. Yes, in which? I'm sorry, I cannot hear you. Please say again. What about hypothyroidism? In hypothyroidism, there is incidence of menorrhagia. So it may be associated with the anemia. Okay. Okay. So I told you that there will be macrocytosis in alcoholism, hypothyroidism. Okay. And hemorrhage, hemolysis. Diamorphic, I just was looking at it in the morning. I have never heard about it. So this is something new for me. It is combined iron and B12 and folate deficiency anemia. Okay. Okay. So we just try to get an what will be the history. We discuss about possible causes. Okay. You see that I told you that if there are some association with the rheumatological disease. There may be patient taking NSAIDs, steroids, drug causing bone marrow suppression, as I told you, in cancers. Okay, so that's what I was telling you. Then actually this will be related to different types of anemia, but usually there will be hemoglobin percentage. We will be doing this MCH MCHC. Okay, and platelet count is important. Platelet count or coagulation. coagulation profile is important with reference to the cause of anemia, because if there is something related to the loss, there may be associated coagulopathy and platelet dysfunction or platelet thrombocytopenia. Okay, so this may be the cause in maybe in aplastic anemia. Okay, and if there is, whenever there is excessive hemorrhage, there will be hypersplenism, and there may be hepatosplenomegaly. Okay, so other reticulocyte will be count will be telling that if there is too much fast requirement of RBC production. So the reticulocytes are the immature RBCs. Okay, so MCH and MCHC and MCV, as I told you, and bone marrow examination in case if you are suspecting any bone marrow suppression, as well as some bone marrow pathology, like in case of leukemia, lymphoma, there may be associated anemia, or if there is, the patient is taking any other like immunosuppressant, so it may be seen, and as there may be metastatic disease, bone marrow metastatic disease. Okay, in that case, it will be associated with some bone fractures and bone pains as well. Okay, we will try to, in our subsequent sessions, we will just try to cover also what is the individual problems, because we should be knowing about the concept of serum iron, total iron binding capacity, and ferritin, because iron is usually stored in liver and some other tissues. Okay, in all, so it is important to see how these values, because they can ask you, they may be asked in the MCQs. Okay, and some other investigations will be related to it. Just a second. Okay. So what will be the definition of anemia? Okay, because this may be the first question when they are discussing about anemia. So can anyone define anemia? What is definition of anemia?
Reduction of red blood cells.
Reduction of red blood cells or decrease hemoglobin, or if the hemoglobin is less than the the required, less than the
6
amount.
grams per deciliter.
I'm sorry, please say it again.
So it is characterized by the decreased hemoglobin at least 6 grams per deciliter.
Okay. 6 gram per liter. Can you correct your answer?
This 6 grams per deciliter.
No. This is not the definition. You're wrong.
The hematocrit less than 30%.
That is, you see, it will be different for different. It will be different for male. It will be different for female. It will be different for newborn. It will be different for infant. It will be different in case of whether the what you say. So actually, some people will define it as it is the decreased hemoglobin than the required concentration according to the age, sex, and physiological or pathological state. Okay, the values will be different, and someone will be asking you what is the WHO. Okay, so WHO may be saying 14, less than 14, or less than 13 in males, and in less than 12 in female. Am I right? Is it like that? But actually, the anemia you will be labeling according to the, because what about this one physiological anemia which occurs in a newborn in like around 6 to 7 months of age? If I'm not wrong, there is a physiological anemia which occurs. Am I right? Okay. Okay, so whenever you are evaluating the patient with anemia, you have to see the possible cause as well. As this is the formula which I was telling you about the oxygen content. Okay, So the main, this is actually oxygen delivery. So, or it is in some books, they will call this oxygen flux. Okay, I will just try to tell you details about it, but actually cardiac output into oxygen content, that is oxygen delivery. Okay, so this is the major content. This 1.34 into hemoglobin into oxygen saturation, and this is the dissolved oxygen, which is dependent on the PO2. Okay, and remember one thing, when we are giving hyperbaric oxygen therapy, we need it for some treatment of carbon monoxide poisoning or gangrene. Okay, so actually we are increasing the dissolved oxygen. Okay, so that's you should be knowing. Which organ in the body has the highest oxygen extraction? Usually heart is taking around 75% of oxygen which is given to it. Okay, so that's why when there is a cardiac patient, you need to maintain higher oxygen, higher hemoglobin levels. Okay, just a second, sorry. This was what I was trying to tell you, that WHO says that it is 13 and 12. Am I right? It may be different in different. What is NCI? I don't know what is NCI. National Cancer Institute. Okay. So this, they have just told you the impact of anemia on oxygen delivery. So they are saying at 15 gram per deciliter, inspired oxygen 21% is the same. PO2 is not changed, and SO2 will not be changed. So what will be the change? Hemoglobin bound to the hemoglobin oxygen, hemoglobin bound oxygen. Okay, the oxygen which is bound to hemoglobin. So do you see this is significantly decreased? So that is the main oxygen. So oxygen content, you see, half. Okay, and due to if cardiac output 5 liter per minute. Remember one thing, that what is the compensation for anemia? How the body compensate for anemia? Can anyone tell?
Increase heart rate.
Increase heart rate, increase in cardiac
Uh,
output. Okay, to be very specific, the cardiac output will be increased. And other thing will be that the physiology of the delivery of the oxygen will be trying to shift the oxygen hemoglobin dissociation curve to the right. Okay, so the Bohr effect will occur, and there will be more unloading of oxygen from the hemoglobin. Okay, so that is, you can just imagine that if you change hemoglobin from 15 to 7, what happened? Remember, there will be no effect on PO2, on oxygen sats. Okay, because oxygen saturation is a percentage of hemoglobin saturated. It is not the exact. Similarly, this is related to cyanosis as well. Okay, so because anemic patient, sometimes they don't get cyanosed. Why? Can anyone answer this question? I repeat my question. Cyanosis may not be visible in anemic patient. Why? Yes,
Because
Dr. Mehnaz. Sorry,
oxygen remains the same.
I cannot understand. Your
Oxygen.
voice is, say a little
Clear.
loudly, please. No, 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 no. What is cyanosis? Cyanosis is more than 5 gram, why 5 gram per DL of deoxygenated hemoglobin.
Yes, sir.
So if patient is hemoglobin of 6, so it will not 5 gram will be deoxygenated. So this is the reason. So cyanosis and anemia are two different things. Remember one thing. Okay. So in this graph, they are also telling as the hemoglobin is decreasing, the cardiac index is increasing up to a certain level. And that is the concept of compensated and decompensated, because at some stage patient will become decompensated. Okay. Initially, patient will try to compensate by increasing the cardiac output, by increasing the oxygen delivery to the tissues, oxygen hemoglobin dissociation curve to the shift to the right, 2-3 dpgs will be increased and everything. Okay, but then a stage will come, well, when patient will go in the decompensation phase. Another reason will be that heart is maintaining a high cardiac output, there will be left ventricular hypertrophy, and then heart may go in failure. Okay, so that is why it is important for us to anticipate. And if, for example, if you don't have hemoglobin to carry oxygen, especially in patient with already which has a left ventricular hypertrophy, the oxygen requirement by the heart will be actually increased. So there will be chances of an ischemia and then arrhythmias and failure. Okay, so that is why anesthetist is concerned about low hemoglobin. Okay, so they are telling in this chart, they are telling causes of imbalance between oxygen supply and demand in perioperative period. Okay, so that is what I was telling you, that there is reduction in cardiac, because there is important factor for oxygen delivery is cardiac output. Am I right? So all the cardiac depressant medications, they are decreasing the cardiac output. Okay, so when the cardiac output is decreased, there will be decreased oxygen delivery. So this is one factor. Okay, then if there is decreased oxygen saturation, because I told you the first step, oxygen transport from the, not oxygen transport, oxygen what you say, oxygen transfer from the alveoli to the blood. So if there will be atelectasis or postoperative pneumonia, okay, or in case of thromboembolic event, what happens in thromboembolic event? What happens, please? Can someone explain? Yes, please. Anyone, please? Because if there will be no cardiac output, there will be no, in thromboembolic phenomena, there will be no blood going towards the lungs. So when there is no blood going towards the lungs, there will be no gaseous exchange. So ultimately, not only the cardiac output will be decreased and actually heart will be failed, and actually there will be no oxygen because no transport has occurred in the lungs. Okay. Further reduction in hemoglobin as a consequence of surgical blood loss or inhibition of erythropoiesis by the altered cytokine milieu. I don't know what is it. Increase affinity of hemoglobin for oxygen due to leftward shift in the ODC by hypothermia. Okay, so that's why anesthetist should be worried about patient getting hypothermic, because it will shift the oxygen hemoglobin dissociation curve to the left. Okay, and oxygen will not be unloaded. Okay, so that is the important thing which you should be knowing. Someone was saying that oxygen carrying capacity is something else. I repeat again, oxygen carrying capacity is something else and oxygen delivery is something else. So this is one of the things which I was telling. Okay, and if there is pain, there is fever, there is shivering, there is stress response, all the bloody things which we are doing is to produce the stress response. Okay, the stress response related to the pain, stress response related to laryngoscopy, stress response related to NCN. Okay, any increased requirement of the analgesia. So multimodal analgesia, that's why so much important. The role of regional anesthesia is, that's why so important. Okay, because regional anesthesia will decrease the stress response. Okay, and stress response is not only this related to oxygen, it will be hormonal response as well. Okay, so we just try that increase oxygen extraction, then redistribution, increase in cardiac output. Anemia causes a decrease in viscosity of blood, which reduces systemic vascular resistance and increase this cardiac output. Okay, sympathetic activation due to sympathetic stimulation of chemoreceptors by hypoxemia may also contribute, but this effect is less sensitive in early stages. Okay, this is more when significant hypoxia occurred. Cardiac output is also redistributed to organs with high oxygen demands. Okay, so this will be also be that in, like, for example, in some acute hypovolemia, that's why there is redistribution of the blood from the skin to the vital organs. That's why there is peripheral vasoconstriction. Okay, this is usually in acute anemia or acute blood loss. Okay, an altered affinity of hemoglobin for oxygen. Anemia causes a rightward shift in oxygen dissociation curve due to an increase in 2,3-DPG and hydrogen ions, which reduces the affinity of hemoglobin for oxygen. Like when this 2,3-DPG is increased because there is increased requirement, so there is increased metabolic. This 2,3-DPG is a metabolic product. When it is there, it is decreasing the affinity, so oxygen is unloaded from the hemoglobin. Okay, and favors the release of tissue to the tissues at higher partial pressures. Okay, so as I told, we discuss. I'm just showing you. We have discussed number of things. Okay, the full blood count should be measured in accordance with NICE guidelines. Okay, and 4 weeks before surgery in order to allow opportunity for full evaluation. So as we discussed these things, anemia with low reticulocyte or in high reticulocyte. It may be due to hemolysis, high reticulocyte count, and non-hemolytic, I don't know what does it mean. Anyways, low reticulocyte with microcytic, normocytic, or macrocytic. Usually microcytic with iron deficiency anemia. So in that case, you are doing ferritin, transferrin saturation, and serum this iron binding capacity. Okay, and when they are doing in macrocytic, they are doing this vitamin B12, folate, liver function test, because there is association with alcoholism. Okay, so macrocytic anemia occurs in vitamin deficiencies, anti-epileptic medications, as I told you. Okay, thyroid disease, alcohol abuse, liver disease. Okay, and normocytic anemia, it occurs in renal and anemia of chronic disease. You know, it's surprise for me that I never read about it. Don't know anyone knows about this dimorphic anemia. This is haunting me since morning when I try to just have a look on this topic. Okay, I hope you people are understanding.
Yes, sir.
Am I right? Okay, because actually if you have the concept, maybe you must be thinking that we are not doing any MCQ, we are not doing any specific topic, but actually if you have the concept, whole of the shop of anesthetist is hemoglobin is low or hemoglobin is high. Okay, so we should be knowing too much detail about all these things. Okay, actually I want to discuss all the small concepts about this. What is this direct Coombs test, indirect Coombs test? I had to revise it. I have asked like at the moment I will not be able to explain to you, but this is in my agenda to explain to all of you. Okay, so I will stop here. Okay, and we will continue from here. Okay, so tomorrow same time we will discuss some things later. I will just share you like I have just tried to grab all the concepts. I will just let me show you so that all of you can have a look at it. Just a second, please. Actually, this is quite disarrayed. Just a second, how to do it? Okay, so actually we will be thinking about the compensation, how the compensation of anemia occurs. Okay, differential diagnosis of anemia and various causes, iron metabolism, megaloblastic anemia, hemolytic anemia. We have discussed some of them. Aplastic anemia, what is role of erythropoietin, how RBCs are synthesized and the fate, the destruction. Okay, what is different types of hemoglobin, like hemoglobin A, hemoglobin A1, A2, fetal hemoglobin, methemoglobinemia, what occurs, cyanide poisoning, what occurs, because all of these things are interrelated. Okay, carbon monoxide poisoning, what is the role of hyperbaric oxygen therapy, and then hemoglobinopathies, as I told. This one of them is sickle cell disease. We will have a detailed discussion on sickle cell disease, all the problems related to sickle cell disease. Okay, thalassemia. Then we discuss some of the aspects related to CBC, MCH, MCHC, MCV, peripheral blood smear, reticulocytes, Okay, blood and blood products transfusion. Okay, as I noted down, direct, indirect comms test, blood groups and cross matching, how to do it, what are the concerns related to it, what are different blood group, what is the things related to RH incompatibility, this erythroblastosis fetalis. Okay, then what are different blood conservative strategies, how to conserve the loss of blood. Okay, as there will be 2-3 scenarios that they will be international exams, they ask about this blood conservative strategy with reference to Jehovah's Witness. Okay, so you should be knowing about it, that how to avoid the blood transfusion, that you will be giving iron, you will be like increasing the hemoglobin levels. Okay, so there will be one category for this thing, and there will be another category, the blood patient with rare blood groups. Okay, or the patient in which you want to avoid autologous blood transfusion. So you will go for homologous, like you will be taking the blood of the patient, you can store it, replace it, give iron. So the same blood may be stored at according to the temperatures, it can be stored for a longer duration, and then same blood can be used. Okay, so this is the concept of what is called concept of normovolumic hemodilution and hypervolumic hemodilution. Okay, there are some oxygen, artificial oxygen carriers, perfluorocarbons that are. Okay, then what is cell salvage, how to do it, what is the concept of cell salvage, what things are important to know about cell saver. Okay, how much, what are the limitations for it. Actually, cell saver is only giving hemoglobin, like it is only giving the RBC, it is not giving the other products. So this is an important thing. What are the different transfusion triggers for each of them? What when we transfuse a unit of blood, what are different products which are formed from it? Okay, RBC, this PRBCs, we do it, then FFPs, cryoprecipitate, then I have not written it here, that is platelet rich plasma. Okay, platelet rich plasma is being used in number of pain therapies, in joint pains, in even in hair transplants. Okay, so what are these platelet mega units and things like that? Okay, blood transfusion reactions, complications of blood transfusion, acute hemolytic transfusion reactions, how to manage them. This is another important, actually, not only in the exam point of view, the practically, how to avoid wrong blood administration, how to check it, what are the different ways to avoid it. Okay, we will discuss. And then these according to the other cell lines, and hemophilia, von Willebrand disease, coagulation pathways, I will just share you with you people. Okay, so that in the coming days we will just try to cover all these. I have just tried to chalk out what are the different things which are needed for us. Okay, and we will try to cover it. Any question up till from our discussion at the moment? We will continue tomorrow, inshallah. Okay, and just try to read about it, and it will, and it try to you see, actually remember one thing, it's for your benefit. I'm just trying to help you out, and it sometimes it's not possible for me to prepare everything, and I'm not a computer that I will recall everything all the time. Okay, because I'm not going towards that typical traditional presentations, because I will start the presentation and finish the presentation and you will not understand anything. So I just try to give you the concept, and when you have the concept, you can read yourself. You are not babies, you are all very good anesthetists, all of you. Okay, so thank you very much. Bye bye. Just please do give me the feedback and try to be in touch, because now you have started. If you don't attend the rest of them, and then it will be of no use. Okay, and all the recordings, they will be available on the YouTube. Okay, thank you very much. Bye bye.
Thank you for the last.